Good afternoon, everyone. Thank you for joining our St. Luke's Health System Talk series. Our virtual classes and programs are brought to you throughout the system and throughout our communities. My name is Erin Buell. I'm with St. Luke's Center for Community Health in the Wood River Valley, but again, we're bringing this out to anybody in our communities that we serve. Before we get started with Dr. Lyons' talk today, I'd like to go over a few features and pieces of information that are important. First of all, we have a housekeeping slide here. You will be able to contribute your questions and comments throughout the presentation. On your screen, you will notice usually in the top right side, there's a conversation box with a question mark, and you can click on that, and then you'll see a field where you can ask a question. Type in your question and then send it to us with that little airplane at the bottom. We will either answer your questions if it might be a technical question, or we will ask Dr. Lyons your question when she takes a break for those questions and answer periods. We will also make sure that we give you time at the end of the presentation to ask your questions. Additionally, we have a disclaimer here. Please note that the information contained in this video should not be construed as your medical advice or instruction. If you do need medical advice, please contact your healthcare providers and professionals. All of this content in this video is part of our St. Luke's Health System, its community partners or their prospective licensors. This video is being made available to registrants for a limited time period for personal and non-commercial use only, and for the sole purpose of your educational information and that is provided therein. All right, thank you very much for joining. And right now I will introduce Dr. Julie Lyons. She is a family practice medicine doctor here in the Wood River Valley. Today's talk is on birth control options and what you need to know. Dr. Lyons.
Right. Thanks for inviting me today. As I have been practicing family medicine full spectrum womb to tomb for 14 years here in the Wood River Valley. I trained at FMRI in Boise, Idaho. I chose my training there in particular because they had a very strong reproductive health tract, and I knew that I wanted to go into women and children's health. So with some of the latest changes that have happened around our country, I felt like it was apropos and timely to talk a lot more about prevention. And as a family doctor, my primary role is to help prevent issues in all men, women, children, and that's my main goal in life. And I think in particular, we can talk about preventing unintended pregnancies, since we know about half of the pregnancies in our country are unintended or unplanned. Some goals of today's talk, I'd like to talk a little bit about, our options through birth control. What do we have? What's new? How effective are they? How do we choose a birth control option that's right for a woman, and how can we improve access to birth control, especially now at our at-risk populations? So in particular in Blaine County, I think our at-risk populations and also in the rest of Idaho include our Latina women. Many of them are uninsured. If you are uninsured, you don't have an easy payment for birth control. Their unintended pregnancy rates are twice their white peers. And there's also some cultural and religious, barriers that may prevent them from accessing effective contraception. On the same line, our uninsured women, as we know, in 2010, when we passed Obamacare, one of the great benefits of it is that people with insurance are provided with birth control free of cost with no copays. That was a huge win for women. But many of our women in Idaho remain uninsured, and that limits our access as well. And then I believe our teen population, again, due to their youth and sort of unfamiliarity with the healthcare system, they are also at risk. Barriers to getting contraception, like I kind of mentioned, the biggest one is lack of access, and people often don't know where to get the birth control, how to get the birth control, how to make an appointment. Not of our, for teens, it's really important to have same day appointments. It's important to have after school appointments, and that's not always the case in our healthcare system. I think also important is the need for confidential care. I'll talk a little bit more about what's legal in terms of birth control in Idaho and not, but many people, don't want to be seen in the waiting room or don't want to make the phone call or are worried about their parents finding out or getting a bill. Cost is also a huge barrier for our uninsured patients. Simply getting an IUD will cost up to $1,500, which is a huge amount of money. And another barrier is the belief that we're unlikely to get pregnant. I think this comes back to the conversations we're having with our children during their teen years and a type of education that our kids are getting provided. Many women and women at risk have poor partner negotiation skills. This might be feeling uncomfortable to ask your partner to get birth control, feeling uncomfortable to talk about sex. That's one of the things I talk a lot about in my clinic. If you can't talk to your partner about sex, you're probably not ready to have sex. And then there's obviously religious beliefs that can be a barrier to contraception as well. Interestingly enough, I was doing some research on our Latina population, and about 90% of Latina women, even though the Pope disagrees with contraception, 90% do choose to get contraception at some point in their married lives. So the religious barrier is definitely something to communicate with our patients about. A lot of parents don't want to think that their kid is having sex. So I wanted to kind of look at, the data. What does the data look like? And in the United States CDC releases a youth risk behavior surveillance system survey. The last one was performed in 2019. This is administered to public schools, and the kids get a whole bunch of questions from, smoking to do they own a gun, and sexual behaviors as well. And on the latest survey, it showed that 41% of our high school kids have admitted to having sex, 30% within the last 3 months. And of those 30%, almost half of them had not used a condom the last time they had sex. And of the children that answered, 14% did not use any method to prevent pregnancy. Even more important is that a lot of sexual activity in teens is related to drug and alcohol use, and 21% of our teens responded that they had had sex or under the influence of alcohol or drugs. And so again, communicating with our teens about the choices that they're making may help them stay sexually protected as well. It also in this study showed that females, the female teens, 75% of them reported their first intercourse was with a steady partner versus about half the males. No surprise there. So when it comes to sex education, it's an interesting slide that I found from the Guttemacher Institute, which again, they have excellent data when it comes to reproductive health that they've collected over the years for our country. Basically, it shows that the majority of our students are getting formal education about how to say no or abstinence, and a significantly less majority are getting instruction about actual birth control. And even in our own health district here, I know in working with our school nurses that there's sort of a fear as to how much sex education we can and can't provide without getting our constituents and parents upset. But I think it's a reminder that we need to not just promote abstinence, but also improve literacy when it comes to health. So I get this question a lot: can teens have birth control without their parents' permission? And yes and no. So yes, they can consent to birth control starting at age 12 in Idaho. They can consent to STD treatment without parents' consent starting at age 14. They, interestingly, working for St. Luke's, these teens are not allowed to consent for procedures. So if they come in and want a Nexplanon, which I'll get to in a minute, or an IUD, which are procedures that a doctor needs to place the birth control in the patient, those teens need their parent consent. So that limits some of the access to some of our best birth control out there. It's also important as the doctor that we need to deem that the patient has sufficient intelligence and maturity to understand the nature and significance of the treatment. And so that's obviously something that a doctor-patient relationship can elicit, and is important from the doctor's end to make sure that it's documented that we had that discussion. So the good news is that teen pregnancy in Idaho has gone significantly down in the last, since 1988 when we started trending some of this data. That's excellent news, and I think a lot of this is due to our significant improvements in birth control that and also more improved access. In 2010, you can see we saw another pretty big decline when birth control access became free for those with insurance. So that was a huge benefit as well. And this is a website you can play around with in terms of looking at the ages and the states and how the trends look. But in general, in the United States, teen pregnancy has gone down a lot. And the reason for this is because contraceptive use is on the rise. And we see here that of the teens that are sexually active, we've seen a steady increase in accessing birth control. In particular, LARC. LARC stands for long-acting reversible contraception. When we talk about LARCs, we're talking about IUDs and Nexplanons. And those have become increasingly more popular, in particular in teens, because the teens are getting the message that they are safe and effective. So these are some slides I stole from one of my favorite websites called Bedsider. Bedsider is a great tool to look at different birth control and statistics and ask questions about it. I'm sorry if they're a little blurry when I blew them up, but as you can see on the top line, we have our most effective forms of birth control that are, you can see over on the right-hand side that less than 1% of women will get pregnant by using these birth controls, and that includes the Nexplanon, the 2 types of IUDs that we have, and tubal ligation, as well as abstinence. Pretty well are pills, patches, rings, and the shot, and those are only pretty well because they actually work really well if you take them correctly. But the issue is that most of us, most humans, forget to take their pills every day. That is a well-known fact in medicine. And if you forget more than 2 pills in a month, or if you forget to change out your patch, then your risk of unintended pregnancy goes up quite a bit to 8 to 9% per year. And then the least effective options we have are pulling out, which is rated about 68 to 70% if you're in imperfect use, and fertility awareness as well. Condoms also rely on the fact that they get put on in time and that they are used without a accident. So back to the LARC, the long-acting reversible contraception. This is a slide that shows just how effective they are compared to our pill and patch users. And on the top line in the blue, you can see that it's not dependent on age. So whether you're a young teen or an older person, such as myself, both the IUDs and the Nexplanons keep you well protected from an unintended pregnancy. As you can see, the pill and the patch, the rates decline quite a bit. And again, that is all due to how well we use this. how well we use these methods. Oops, I went too quick. Okay, let's talk about each type of birth control. Oral contraceptives have been around for years and years and years. The good news is that the doses that we start women on now are significantly lower than the doses that we originally invented the pills for. So my mother and women in my mother's generation, you know, were put on very high doses of birth control pills with severe side effects, and all sorts of negative connotations came with that. But over the years, we've been able to reduce to the minimum amount of hormonal content to prevent ovulation. And again, that's the main thing that oral contraceptives do, is prevent an egg from being released by using the hormones that our own bodies are making, but just using them at different concentrations to prevent that fertilization cycle or ovulation cycle. Pills come in different forms. It is important when we're prescribing pills or when you're picking a pill up that you look at your box and that you see if you understand correctly how to take it, whether it's in a circle from going around in the direction, or in a line like you're reading a book, or in the back you can see one of our pill versions where you take that continuously for 3 months, and then the yellow is the month that, or the week that you can have a period. That's becoming increasingly more popular, especially with our teens, especially with our athletes who don't necessarily want to have a period, you know, once a month, and it might interrupt some of their athletics. So we are now able to skip periods. I get that question a lot. Is that dangerous for my body to skip a period? It's 100% not. What we're doing is sort of keeping the lining from building up by giving that continuous birth control. So there's nothing to shed. It doesn't cause harm. It doesn't accumulate inside of you. It doesn't go up to your brain. So it's completely safe to skip periods. You can skip a period with the regular pack of pills too. You just do 3 weeks, and then you skip your sugar pill week or your last week and go directly onto your new pack of pills. Your doctor does need to prescribe it that you're taking it that way, or you'll run out before the year's end. And that doesn't increase your risk of pregnancy by taking it that way. You know, there's always questions as to whether birth control pills and or the shot cause issues like weight gain. When we look at the studies on oral contraceptives and also on DEPO, which I'll get to in another slide, we really don't see a direct influence on weight gain with birth control pills. What we do know is that women gain weight, and a lot of times when they are starting to become sexually active, they're in that late teen years where our bodies are naturally starting to gain weight for a whole host of influences. And so it's probably not connected exactly to the pill itself that causes that weight gain. But when it comes down to the DEPO, which is the injection, if a woman is gaining more than 5% body mass on the injection within the first, 3 to 6 months, that's probably a sign that it may be influencing her weight, and probably she's not a good candidate to continue, and we should pull her off at that point. So like we said before, pills work only if you take them and put them in your mouth every day. There's wonderful apps out there that I tell my teens to download that remind them to take their pills. I try to remind them to place an extra pack in their car in case they go away for the weekend or whatever, they can access it. And then I always say if you miss 2 or more pills in 1 month, whether it's right in a row or one week and one the next, that is your sign that you can get unintendedly pregnant and that you need to not be sexually active for 7 days until you get 7 hormone pills, not placebo pills, hormone pills back in a row to prevent that chance of ovulation. Any questions?
There aren't any questions now. Sorry, I'm just going to remind everybody, some people joined late, I can see. Just use your Q&A feature and type in your questions along the way. And thanks, Dr. Lyons.
So moving on, we have the ring and the patch, which are the exact same hormones that are in the combined birth control pill. They have the estrogen and the progesterone in. I'd say these are somewhat popular, but the ring, you do need to feel comfortable inserting it into your vagina and keeping it there and then removing it. And the patch is something that you need to put on once a week and change once a week. In particular, in the summer, some women will complain that the patch is visible or that it falls off if they swim or sweat. But again, those are the same type of hormones that the pill has, and they are slightly, maybe we could argue slightly easier to remember, maybe slightly harder. I guess it depends on how you look at it. They have, you'd expect similar side effects on the oral contraceptive pills as you would for the ring and the patch. The injectables, as I mentioned before, the main one or the only one we have is Depo. Depo is a progesterone hormone that we inject every 12 weeks. There's also now some studies showing that we could have women self-administer their own Depo at home and also have great efficacy and higher uptake, and that you don't have to come into a clinic every 12 weeks to get the injection, which is a barrier. So that's hopefully in the works that we'll be able to self-prescribe that and send patients home with that, since we are doing lots of injectables for our diabetes therapies these days as well. Another concern that comes up with Depo is, does it reduce your bone mass? And similar to like when you are pregnant or breastfeeding, the hormone progesterone does cause some bone mass, your bones to leach some calcium, and you can see a small % drop in your bone mass while you're taking this and while you're also pregnant or breastfeeding. But the good news is that it comes back after cessation, and within a few years, you're back to your baseline. So it's not a reason to not give somebody Depo, no matter what their family history is with bone, with osteoporosis or whatever. We always remind women to, eat your calcium. It's important that we get our calcium, especially our women 25 and under. They're still building their bones. They should be eating calcium in their diet, and they should maybe be taking a vitamin D and doing weight-bearing exercise and all the other prevention techniques like not smoking and reducing alcohol to help keep good, strong bones. But there is no reason to withhold Depo because of fear for that. Some women will get, I think the biggest discontinuation problem with Depo is irregular bleeding. About a third of women will get no periods on Depo, a third of women will get a regular period, and a third of women will get irregular spotting. I think those are the women who feel most discontent with it. There's a few tricks that we try if a woman does like Depo and wants to continue it, to try to get her spotting under control, including actually taking ibuprofen continuously for 5 days. Sometimes that in itself will stop the bleeding cycle. The bleeding is not usually heavy, doesn't usually cause anemia. It's more of a nuisance, and usually at if we can continue your Depo for about 6 months, by the 6-month mark, the majority of women who were having some unpredictable bleeding do end up becoming amenorrheic or no period, and then they seem to tolerate it better. Any questions?
Nope, not at this point.
Nexplanon is a very popular one these days, especially with my teen patients. Nexplanon is the same hormone as our injectable, as the Depo-Provera. It is progesterone. It's a tiny little rod that we insert in your arm right here. It's this long. I didn't actually make a picture of it, but this is a picture of the applicator. It's very, very easy to insert, much easier than the old-fashioned Norplant. For those of you who might have heard of Norplant years ago, when I was working as a medical assistant at Planned Parenthood, we would, sometimes take an hour or so to remove all these Norplant rods because there were several of them in an arm. This is one rod. This is a birth control that's effective for 4 years. And again, easy to insert. It's private. That's why teens like it. It's not an obvious thing that you can see or hear about. The woman can feel it often through her skin, but that's about it. Similar to the depot, it has the same irregular bleeding patterns as its #1 side effect. So a third of women with no period, a third of women with irregular spotting, and a third women with a period. And again, if we can get you to the 6-month mark, usually that bleeding does get better. And I would say, but if it doesn't get better, that's probably the #1 reason I take it out, is for the bleeding, not for other side effects. So IUDs have been around for centuries, eons. They've come in different shapes and sizes. We have 2 main types of IUDs right now on the market. One is progesterone coated. So that's our Mirena, Liletta, Kyleena. The other one is hormone free. So it's one of our only hormone free ones, and it's called the Paragard or the Copper T. An IUD is highly effective at preventing unintended pregnancy. It's the most effective besides sterilization and abstinence. And it does require a procedure to insert it. It can be inserted in any woman. You don't need to have had children. You don't need to be adult, teenagers. It's becoming more and more popular with teenagers. And again, is highly effective, 99.7 to 9% effective. The hormone-coated ones are designed to release a small amount of progesterone into your uterus, which I describe, it keeps the lawn mowed. So you're not building up a lining every month, so there's nothing to shed. Some women might get some spotting with it, especially in the beginning. Usually that goes away, and you might just get a little bit of spotting on the time of your cycle. I always warn people, you still will cycle on these, even if you're not bleeding. Your ovaries still cycle and produce your hormones. You can still get PMS. You can still get sore breasts. You can still get mood changes with your cycle. And so to be aware of that when you have these, they are not the cause of those, but they are part of your natural cycle. Let's see, what else do we want to talk about with these? The insertion is quick. It's slightly crampy. We try to pre-medicate our patients by telling you to take ibuprofen. You can bring a heating pad or use the heating pad after. But the intense cramps last for about 30 seconds. And within a minute or two, most women have their cramps are rated at a 3 out of 10 after that. And for the next day or two, you might have some dull menstrual cramps. And then after about 48 hours, I always tell women you should never know what's inside you. You should be able to run, jump, stand on your head, have sex, and go on with your day. They are very easy to remove. There's a small string that hangs in the vagina. Most partners can never feel the string. Sometimes in certain positions, they may feel a poke, and if that's a consistent problem, we can always trim the string. But the string is there so that we can easily remove the IUD. There's no increased risk of fertility issues or tube damage with IUDs. That's a myth that's been busted. And the hormone ones work by creating a very unhospitable environment to ovulation and fertilization and implantation. The hormone-free one is coated with copper. The copper creates an ionic environment, which again acts as a spermicide to kill sperm and create an unhospitable environment. And the non-hormone ones are valid for 12 years. Our hormone ones, our Mirenas, have just recently been updated to be good for 8 years. Every year they go to the FDA with more research to buy another year. So they originally had 5 years, and then now we're up to 8. And with the Lilettas, which is what we use at the St. Luke's Clinic, they are valid for 6 years and probably will get that 8-year validity at some point as well. So again, these are the most popular birth control in the world. Many countries, this is their primary form of birth control. In the United States, it's catching on. You know, I probably put in an IUD every day in my clinic, and have seen very few complications over the course of my career. There's a very rare possibility of perforation, which I think is what scares people, although the reality is it's pretty challenging to perforate the uterus if you're well trained. And this is primarily occurs in women who are immediately postpartum, whose uterus may be stretched out from a baby, or perhaps someone who has an undiagnosed connective tissue disease like Ehlers-Danlos syndrome. But in the average healthy woman, there's really no concern for perforation. About 3% of women can expel their IUD. The data says it's most common in the first 30 days. So I always warn the women, like after those 2 days of cramps, you shouldn't know it's inside of you. If you start feeling cramps again, if you start feeling pain, if you feel pain with sex, like this could be a sign that maybe your IUD is shifting and maybe you're that 3% that needs an evaluation to see if it's coming out. And in our clinic, we can easily locate our IUDs with our clinic ultrasound to see if they're in the right place or not. So many clinics bring their women back after 6 weeks of placement just to double check that it's working okay and answer any questions. And some even offer ultrasounds if there's a concern.
Dr. Lyons, someone is asking a question if Nexplanon is considered a procedure.
Yes, Nexplanon is considered a procedure, so therefore a teen at St. Luke's does need their parents' permission to have it inserted. I'll touch on barrier methods. They're probably the least popular. I haven't prescribed a diaphragm in 15 years. I don't even know if we still have a diaphragm fitting kit in our clinic. However, they were way more popular in the 70s and 80s. A diaphragm you insert, you fill it with foam, spermicide foam, and you insert it like a tampon, and it blocks the cervix and kills the sperm. The cap is a similar one. It's smaller than the diaphragm, and these require very significant comfort with your body and placing your fingers in and out of your vagina and making sure that you can feel your cervix and put it in the correct place at the correct time and take it out correctly and wash it correctly. And so I'd say they're probably our least popular, but they are an option because they are one of the few hormone-free ones. Spermicides, again, work best with condoms. They're not designed to work alone, although we do have a new spermicide on the market called Phexxi. Phexxi is getting some good track because it's made with 4 natural acids that your vagina already has in it. It reduces the pH of your vagina to its natural state, which then acts as a barrier or as a spermicide to kill sperm. I think they're saying it's about 86% effective, and that's without condoms. Again, we don't recommend just using it, but it's a great new option on the market. It's been increasingly covered by insurances. Otherwise, you're looking at $300 or so out of pocket for a pack of 12 of the Phexxi applicators. And the Phexxi also is showing some data that it may help kill chlamydia and have some STD prevention as well.
Another question came in, Julie, probably Dr. Lyons, probably related to the parent consent one that was earlier asked. Do both parents have to consent or just one for these teen situations?
Just one if they are married, and I believe in a divorced family, I think both parents have to consent, but I'm not the expert in that. My front desk would know. I'll mention the rhythm method in order to be complete. I think The benefit of a rhythm method, I think, actually is more beneficial when you're working on trying to get pregnant, not trying not to get pregnant. It's very helpful when we are studying our fertility. It works well for women who have regular cycles. You need to have regular cycles every month to be able to predict when your most fertile days are. And on your most fertile days, which is days 9 through 20, then you would abstain from sex. Again, that's assuming a regular cycle and a pretty good knowledge of your own body. You can tie it in with cervical mucus and basal body core temperatures as well. So here is my slide on Phexxi, which I mentioned under the spermicides, 86% with typical use, and you self-administer this, kind of like inserting a tampon. It's an applicator that you push up into the vagina within an hour before sex. Obviously, you can't use it after you had sex. It's for before. It's not a it's not a form of emergency contraception. I'll mention a few other new ones that I don't have slides on. We had a new ring that was FDA approved. This ring is a reusable ring that lasts for 1 year. So you put it in for 3 weeks, you take it out for 1, you put it in for 3, you take it out for 1, and it's good for 13 months. It's the same hormones as the birth control pills in the other ring. But this ring is a slightly larger version, and it isn't as sensitive to temperature dysregulation, and that's on the market. There's been two other different hormonal birth control pills with slightly different types of hormones, more specific type of progesterone, estrogen, that have been on the market as well. I'm trying to think, there's an IUD being tested in Israel that is a smaller circular version of the hormone-free one, and that may show up in the United States at some point as well. Options for men remain extremely limited. We've got the vasectomy, which is a very straightforward procedure that's done in a clinic setting. It's way, way, way easier to perform than a tubal ligation on a female. It's done, like I said, in a clinic with some Valium, with some injection lidocaine numbing medicine, and then you find the vas deferens, which looks like spaghetti, and you cut them and sever the ends, as you can see in the picture. This is also covered under Obamacare as a preventative measure, so many of our men are getting these for free. It's important that you be 100% sure that the man does not want any more children, because it is very challenging to reverse it. We also have condoms, which come in all different sizes and shapes. Nothing is too new on the condom front. Some of them have spermicides that come with them. Other ones you can put spermicide in the tip of the penis before you put it over the penis. New on the horizon for men, they're studying a cream which they'll rub on their back and shoulders, I believe, that will stop the production of sperm in the testicles. I don't see that one going over too well with our men, but it's getting tested. And I'm not sure if there's anything else. I feel like there might be another one. I can't remember. So emergency contraception is what happens after you had sex. This is not abortion. This is a forms of birth control that you use after to try to prevent ovulation or delay ovulation. The most common known one on the market is called Plan B, and there's several generic versions of that too, and Ella is another version. These are very important that you take them as soon as possible. They are over the counter, but you have to be 18 or above to access it without a doctor's prescription. We in our clinic try to practice that if we're giving someone birth control pills or patch, that we also give them a prescription for Plan B, so that in the event of an emergency where they did forget pills or forgot to put their patch on, that they have access to it. We have a local pharmacy that's donated 300 Plan Bs to our community to use for these times for accidents. We don't like to recommend this as a form of birth control, just as a backup way to prevent. They're about 75% effective at preventing unintended pregnancy after the fact. The lesser known version and probably less common version of emergency contraception is placing an IUD in within 5 days of sex. That because it has the chemical copper reaction will prevent the fertilization implantation and can be used as a form of emergency contraception. Obviously, that one's trickier to access. You have to have an appointment, which most of us are booked out, quite a bit in advance. So it's not a super common way to use emergency contraception. In our local area, one of our medical students actually made this beautiful pamphlet on how local Blaine County residents can access birth control and emergency contraception. One of her parts of her research was kind of pricing out what this costs at our different pharmacies. You can see that they're quite a range. Our newest Family Health Services is our cheapest range, but that would be in conjunction with a healthcare visit as well. You can also buy these online, although they are not overnight shipping, so you would need to make sure to have that in stock at home as a backup. Most of us at our clinic would be happy to provide a prescription to our teenagers through our telehealth services, which can be done either through a phone call or a video consult, so as to help reduce our barriers. So it's the kind of gist of what I have for my talk today. Remember, birth control is something we can all agree on. It's a preventative medicine. Shouldn't be controversial. My recent work with the Idaho Medical Association, we are working to help lobby to keep birth control and Plan B legal in Idaho. There is some concern that Plan B may be the next up on our potential for things that the legislature may pass. That would be a shame, given that it's a hormone called progesterone that our bodies are naturally making. So make sure to be on the lookout and talk to your legislatures if we hear anything about having birth control become illegal. In terms of which birth control is right for a woman, the most important thing is to pick the one that's right for you. I always say they all have side effects. You just have to pick which side effects sound good for your body. And the good news is if you pick one and you don't like it, we'll pick another one. We can try again. There's a lot of options out there. And it's nice that we have these options and that we have these reversible options. A reminder that LARC, long-acting reversible contraceptives, are one of our best ways to prevent unintended pregnancy, and they have become increasingly popular. They're extremely safe. They're safe for all ages, and to make sure to ask your healthcare provider more about that. The links below are 2 great resources for birth control that I like to share with my patients. The bedsider.org has great information and can be translated into Spanish as well. And that concludes my presentation. Any questions?
Thanks so much, Dr. Lyons. We're waiting to see if anybody has any questions, and you can, again, click on that Q&A conversation bubble at the top of your screen and type it in on where the cursor shows. I would just like to remind people too that you might be eligible for maybe Medicaid or something to help you pay for some of your medical procedures and appointments, and that you also might be eligible for, St. Luke's has a patient financial care program to qualified individuals to see if they can maybe get a reduction or a write-off on part of their medical bills. So please inquire. Front desk access, patient access people have more of that information, or go onto our website, the St. Luke's online website, and pay a bill, and you'll find the financial care application in there. No questions are coming in at this time, and I appreciate all of you listening in today. Go to stlukesonline.org/health talks and see what else is coming up.